Welcome everybody to the session on Change Ahead, Balancing the Patient and Caregiver Experience in a Human-Centered Virtual Healthcare Delivery System. The providers who have been using these new technologies have not necessarily been trained on them. They don't know all of the nuances around the new technology. So we've got a great panel that David Burke is going to help introduce here. David is from as a partner at Guidehouse. He's going to moderate our session today. He's a senior leader in Guidehouse's commercial healthcare segment. He's also a founding member of the firm's Innovation Development Council, which is just a fancy way of saying, whenever you try something new, who makes the decisions about what you should try, how you should do it, how are you going to measure the results around it? So David, take it over.
Thank you, Shane. Appreciate that. And let me in turn introduce you to our panel today. Let me start with Pamela Aurora from Children's Health. She is the Chief Information Officer there, and I believe if I went to her office, there'd probably be a really large trophy case right outside of it, because this is a very well recognized and well decorated organization for digital and IT performance. In addition, also from Children's Health, we have Tamara Perry, who is the Senior Director of Virtual Health. And keeping in line with an organization that has put a priority on this for a long time, Tamara currently serves as the chair of the American Telemedical Association Pediatric Special Interest Group. We also have Michelle Stansberry, who is the VP of Information Technology for Houston Methodist, and she has been there a while and accomplished, like many leading institutions, telemedicine and DigiHealth just didn't show up 4 months ago. So there's a long list of accomplishments and system placements that Michelle has put in place at Houston Methodist, which has enabled them to see this spike. And now the question is it a spike or is it a systemic change? So Michelle, thank you very much for joining us. The first theme is healthcare is often criticized, perhaps, that it doesn't embrace customer-facing digital technology as quickly as other industries. So nobody's seen a teller at a bank in a long time, but we still see plenty of clerks when we go to the hospital or to the physician's office. But at the same time, ironically, we're also an industry that's very quick to declare paradigm shifts. And the other element that we're going to address in the next half hour is 2 of the 3 panelists are in a children's hospital, and Michelle was part of the Houston Medical District, and there's a really big children's hospital down the road. And I think a lot of people forget, particularly if you listen to your news report at the end of every evening, pediatric populations do not pop up as being particularly at risk. But then you have to remember that the children don't come to the outpatient center by themselves. I bet you that you had this boom in telehealth and digital activity. And you're probably being asked by your leadership colleagues, how much of this is really going to stay digital and how much of it is going to return to physical visits again? So what do you think is happening?
No, it's a very good question, and I will tell you it's something that we've often wondered, even with our very first surge. And I think many know that Texas is going through its second surge, which is a lot worse than what we had seen during our first surge. But kind of the difference for us was that at the first, we shut down all our clinics. And, virtual health wasn't new to us. We've been doing it. We had it in place. But we hadn't had high adoption yet. Great in our primary care, a few of our specialty groups, but not widely used. And we had also had a pilot that was going on for virtual care within our inpatient setting, within our ICU. But guess what? COVID hit, We had to close down everything. We still needed to see patients though. So whereas we were probably had around 50, 75 visits per day, within a very, very short time frame, we quickly trained over 900 physicians to be able to do virtual care. Some of that was done in classroom within our Center for Innovation. And most of the things, I am also our vice president of our Center for Innovation. So a lot of these things came out of our innovation for digital technology. But had to quickly get them trained. And then, of course, as you're going to hear from others on here, quickly jumped up, right, to just this exorbitant number. Ours was like 3,000 per day. We also took our virtual business within our ICUs. And we had, as I said, a short pilot that was going on in our neurosurgery ICU, but we quickly had to go within a 2-week period and across our 7 different hospitals, really ramp up so that we could protect clinicians as well, but still be able to have communication with the patients when they needed to, making that virtual call to them. What happened to us in our second surge, and I know this is kind of what your initial question happened. Yes, we did. We took we saw a drop that occurred as the clinic started opening back up. Patients did want to come in and have that face-to-face. We never really dropped down to our initial numbers because a lot of our physicians who were maybe hesitant to go and use telehealth absolutely loved it now. And so, we're able to really, when they ramp back up on their clinic space, they did want to leave room to be able to do some of those virtual visits. So it did drop back down. Now as the second surge has come up, we have kept our clinics open. We are still doing normal business within our hospitals. So we haven't seen it go up to the numbers that it did previously before, but it has spiked up some. On the inpatient side, if I could just tell you, because we are seeing a greater population now than what we did during the first surge, it has been extremely beneficial for us. The other thing that we're using the technology for, which is different, what you're going to hear from the children's side of the house, is that family members aren't allowed. They are not allowed to be able within the institution. So we have used this same technology to allow the patients to be able to communicate with their family members who are not able to come in and see them. And so that's what's been beneficial for us. But I think the real question, and it's for all of us, where is this going to plateau out at? And I don't think any of us really know at this point until we really get a good handle on what's happening with COVID.
Mm-hmm. Thank you. Tamara, are you seeing the same events, the same outlook that Michelle just described, or?
I'll start, but Tamara can go into a lot of detail. As our trend, we really have had a program that's been grown over a decade. But as far as COVID, the level of adoption across the hospital of all these different subspecialties has just exploded. The interesting thing, though, is in some cases, some organizations are going to find they're going to go back to pre-COVID when the surge passes. In the case of children's, it's always been part of our strategy. And it's been just a complete pleasure because we've been building these programs over time. But the key is building programs that will continue to have that elevated adoption, not only within your hospital walls as far as subspecialties, but across the community. Our phrase is we like to be where children live, learn, and play. We have a very extensive telemedicine program into the schools. And we've had some interesting ways where we've even been able to redeploy some of that equipment when some of the schools have been going to total virtual. So as we're taking a look at different options, I think like Michelle, you'll find it interesting. The first areas we penetrated relative to deploying telemedicine back into some of the more sophisticated areas in 2013 was the ICUs. Because it's just such a great use case for leveraging that technology. But it's one of those things where before it was boutique doctors that were willing to adopt it. Now everybody's adopting it. They're seeing the utility of it. the patient families aren't going to want to go back because they're certainly seeing the utility of it. And for Children's Health, we plan on staying with this kind of elevated adoption because it has been part of our strategy. I'm going to pause there because Tamara has a lot to add to this conversation. Please.
Yes, I can certainly say firsthand, just kind of operationalizing all of our telemedicine programs since the beginning of our journey. It has a lot of providers, clinical staff, leadership, down to the finances of it all have been pushed into really a new care continuum. For us in telemedicine, we've been waiting for this day. Been working in telemedicine for about 15 years or more in the both adult and in the pediatric space. And we've been waiting for the day. Now, we didn't expect the day to happen in one day, right? and it has. So for us, I just submitted an abstract for our research endeavor, and I titled it 0 to 60 in 30. The deployment of ambulatory telemedicine in our ambulatory spaces, our bedside telemedicine, huge increases, as kind of Pamela alluded to earlier, 16,000% increase. We're at a near 25,000 visits since March 19. So just to step back a little bit, for sure, our experience working in the pediatric space really started in our schools. We have around 189 school-based telemedicine sites where we train those nurses to see one of our full-time providers over a telemedicine mobile unit and provide care to those students. So with that, we've done that since 2013, 2014 or so, and we've seen an increase. This for us, and we're used to kind of rapidly deploying. How this shifted, it wasn't the mobile units and that kind of technology that's being used. It's where patients are at home, right? And for us, our pediatric patients at home with their families and using their own devices really to be able to see a provider. So we saw that shift in regard to how that empowered families to be more really in control of their care, understanding what their blood pressures were, even for pediatric patients, and understanding that they can still connect with their provider when they're not either at school or going out to a clinic space.
So the adoption rate is what everyone thought it would be, and here it is. But we also know that in the health systems are used to geography. And geography is really important, but in digital worlds, to use Friedman's term, they're flat. So in the past quarter, as you have been seeing this mass adoption for this technology, have you discovered any new competitors that you weren't tracking before? I'm just curious. Has anyone become aware of a new competitor in this arena?
Yes, for sure. We've in virtual care, we've always had quite a few of competitors, and we like that. That mixes up the game a little bit. The disadvantage of that, though, for healthcare systems is those that have not really had the experience in virtual care are not aware of kind of which technology to choose. I think as you know, Pamela and us at Children's, we work very closely with our technology departments to vet out the technology. What is the best use case for different modalities for virtual care? And with the rapid deployment of telemedicine, a lot of the hospitals just hadn't had the time to really vet out some of the platforms, some of the technology use cases, and it has put them at a disadvantage as we're kind of talking about sustainability of programming. If I've heard, in just my experience working across some of the hospitals in the country, a lot of the telemedicine technology groups are offering maybe free or no pay contracts at the beginning just to get telemedicine started, and then maybe some inflated prices, as we're, down 6 months into the programs. Hopefully that will not happen, and hopefully it's just, rumor that it will. But I know they're giving out some freebies, but I think it's very important, just not the cost, because sometimes you have to buy in and pay in to get what you really need. Cutting costs, cutting on those things sometimes can hinder your program. So I would say for any of those hospital systems, the virtual care department working along with the IT department, with the EMR groups, with the legislation, we've talked about legislative groups inside of your hospital is the best case scenario. So you can have all the players, stakeholders at the table to make the best decision in regard to the technology that's being used and the way the programs are being rolled out. So yeah, we've seen a competition in school telehealth for sure.
Michelle, I think you made a reference to having to train your clinicians and your caregivers. And of course that begs, because everyone seems to be telling me that we're going to see these volumes for a long time. So how do we make sure that our clinicians are trained, like this stuff, are ready to be proficient and effective with the technology we're going to be putting in for our patients? So what steps do you anticipate?
Let me I want to jump back to your other question, because I do think it's very interesting. We were 2.5 years ago, almost 3, when we started our telehealth program. We were pretty much the first here in the Texas Medical Center. And since that time, and the reason that we did it, we had seen where it was coming across the country. We wanted to get it up in place. I think what you find now today, everyone's doing it. Your CVS, your Walgreens, your Walmart, every little shop here. And so that's what hospitals are competing with, right? So it isn't just, and I am agreeing with, Tamara, on the technology, but it also has to be the ease of use for the patient. If it's hard for them to get in and it's hard for them to use, guess what? They're going to go down to the CVS's, or they're going to go down to the Walmarts. And so that's one of the other things, is that, making sure that you are choosing the right technology, not just for the hospitals or the healthcare systems, but also what's the ease of use for the patient to get into it. Now, let me go back and address your other question, which was on training. Yes, I think all of us, and this isn't a unique story to us or, with Pamela or Tamara. If you talk, this is a common story amongst all healthcare institutions right now who are having to deal with COVID. How do you sustain it? Well, this is like any other training. Whenever you come in and you train your docs on how to use the EMR, you've got to be able to train them too on how to do telehealth. How are they going to do it? And, we use, of course, our EMR. We use it as part of our virtual program that we use. And so I think is newer clinicians coming on board, it's going to be easier for them. I think that's the reason we kind of saw the low adoption, which is, from physicians who had been, practicing for a while. They were used to seeing patients, in person. What do you mean I'm going to see them, by a virtual? How can I do that? I need to be able to, touch and, hear things. But I will tell you, we're trying to supplement our virtual health with, not sure if any of you are familiar with TytoCare. It's a device that the patient can purchase themselves. It allows the clinician to be able to, listen to heartbeat, get blood pressure, look in the ears, look in the throat, which helps the clinicians further to be able to make that clinical diagnosis. So how do we sustain this? I think it's just another part of the training that you have to take when clinicians are new to your facility. They go through the EMR training. They're going to go through training on how to do virtual health. And it is our strategy to continue to keep exploring how that we can, do this further. Right now we're kind of taking the Houston and surrounding community, but we do have a very big global population, and we're looking at how we can extend it beyond that as well.
I wanted to underscore a few comments that both Tamara and Michelle were making. One relative to adoption. We had a program in for a good long time, but we were still training 1,300 physicians and 1,000 nurses in the course of this event. So it gives you an idea of just what the scale of adoption is. In addition, when you're really trying to get the adoption in the community with patient families, that's where the convenience factor comes in. Our phrase is we want to be where children and families live, learn, and play. CVS is convenient. Well, the Walgreens are convenient. And Tamara and I were talking yesterday, and many times clinicians don't realize that what's convenient to the patient family might be that Wi-Fi at Starbucks versus in the home setting. And some of the clinicians have had to get used to this new setting for the consumer side of it. And we have to be into that new normal because frankly, that's where the CVSs and Walgreens are going. And that's where we're at. But at the same time, it took some orientation of those clinicians that were being trained. Tamara may want to elaborate on that.
Yes, for sure. Just for the, convenience, Michelle, as you kind of mentioned, for the patient, when we first deployed our Children's Health Virtual Visit app back in 2015, which is a direct consumer app that allows for patients and both adult and children to be able to see a provider from home, the Texas law stated that you had to establish patient-provider relationship in a clinical location. So that was very tricky because clinical locations were, a pharmacy or a school clinic was one of those. But so we deployed kiosk out to pharmacy areas, retail locations that had pharmacies, and then some private kind of owned living facilities with a medical assistant. So we could have that first visit be done at a clinical location. Then 2017, the law shifted where you could establish patient-provider relationship over video without there being at a clinical location or having a telepresenter. So then we were able to really roll out that Children's Health Virtual Visit platform for them. And so patients could be able to see from home as needed. Medicaid still has a few kind of restrictions in regard to that, but for the most part, you can have an urgent care visit from home. So what we had to really do is look at the technology in regard to what was most effective for the patient, but then also as Michelle and Pamela both alluded to, what's efficient for the provider. So, we got 1,300 providers and more trained during this time. But I think what's interesting is that the training itself had to change. We have a pretty tight curriculum in regard to telemedicine training. A few of the universities here in Dallas have reached out to us to help them develop telemedicine training, which is very interesting. So now they're going to be including it right into their provider training. We have a resident program where the residents come through and are trained in telemedicine and see our program. But what we had to, and a lot of that is didactical, right? So you're in the room with the provider, with a scope, whether it's the Title Care or the video or whatever the names are. You're sitting there, you're with the scope and you're demonstrating really how to place it into the ear and how to work with it. We had to shift that training to a full virtual experience so that we were limiting the exposure of our trainer team, even though they're clinicians, and then the providers. We wanted to rapidly deploy that. So what we did, what we would have usually done in person, we transitioned that to a virtual experience, either group training or video training. So there's a couple of phases. There's a baseline knowledge of telemedicine that they learn what telehealth is, telemedicine is, and the laws around it, but then also what the technology is, and then some of those basic pieces of knowledge as to how to look through a camera and how to work through those pieces of it and explaining what it is. But we had to switch all of that to a virtual experience due to COVID, which is a fast turnaround and credentialing in 24 hours instead of the usual 2 months that it takes for her. Michelle's laughing because she knows it takes a while to get the credentialing done. But we had to shift that, and our credentialing team was awesome. Medical Affairs, they would turn it over for us in 24 hours. And so we got quite a few clinicians, over 1,000 or so nurses trained within that space.
Another element that supported this adoption rate is suspension of regulations. So this is a heavily regulated area, and the regulations weren't always designed to facilitate adaption. So we'll see state by state basis how rapidly suspension becomes eliminated, and that will play out in the months to come. So with that, I think we probably have inspired a lot of questions with the expertise and passion that's on display here. So why don't we check it out and get some questions from the field.